First of all, make sure that you're testing every patient first line for EGFR mutations, and work with your pathologist, work with your hospital to make sure that they're doing this quickly. It needs to be back basically within 2 weeks. You need to make sure that when you see the patient in a truly meaningful amount of time, you can have that information so that you don't have to wait and potentially people get too sick to get treated before you start. The second thing is, don't treat people with an EGFR inhibitor unless they have a mutation. We have very good information that if you start everyone on an EGFR inhibitor and they don't have a mutation, they actually do worse. Patients don't live long enough to make it to chemo if you wait to find that it's not working. So test everyone, but only treat if you find the mutation. When you do have a mutation, there's 3 good choices. All of them are very reasonable: gefitinib, erlotinib, and afatinib. There may be a little bit of evidence that afatinib is more effective, but it's probably not a huge difference, and it does have more toxicity. So you can use these criteria to pick this. And then finally, we actually now have an approved drug for people who have acquired resistance to the first and second generation inhibitors. And so it's very important that you get a biopsy of people when they progress on their EGFR tyrosine kinase inhibitor, because if they have the most common resistance mutation called T790M, we have a drug we can prescribe them that is very well tolerated and very effective in this population. It's called osimertinib. It's a mutation-specific inhibitor. It has very little of the wild-type side effects that we see with the first generation and second generation inhibitors. It has a little bit of rash, but for patients who were previously on the first generation drugs, they say they don't even really notice it. They have very little diarrhea. They do still have the same minimal risk of interstitial lung disease that we see as a class effect among all EGFR inhibitors, but very tolerable overall, and with a response rate of over 60%, clinical benefit rate of about 90%. So this is not something you want patients to miss, and you can't find it if you don't look for it. So patients need a biopsy to identify that mutation.